a case scenario dealing with colorectal cancer, but I need your interaction. So this is supposed to be interactive. And the target of this is not only the cancer, to be familiar with lower GIT symptoms and to be familiar with lower GIT relevant signs, and to be familiar with the differential diagnosis of lower GIT problems, lower GIT investigations, and to be knowledgeable about rectal cancer in particular. I hope by the end of the session you will be aware of this. So let's say that you encountered a male patient in the outpatient department who is not happy about his abdomen and defecation, and you are interviewing the patient. So the patient is telling you he's not happy about his abdomen and his defecation, and you are interviewing the patient. Mention 4 important questions in the profile. What do you want to ask this patient in the profile? I need you an interaction. This is an interactive session.
دكتور، أول شيء ممكن أسأل إنه متى بلشت هاي الأعراض؟
Of course, you need the duration, etc.
هو حكى في problem بالديفيكيشن يعني بالباول موفمنت، فممكن أسأل إذا في change in any bowel habits صارت recently، يعني شو ال change diarrhea ولا constipation؟
Change in the bowel habit. Okay.
السؤال مش
بس انتوا ما انتبهتوا انه احنا هون بنحكي على البروفايل.
Is age دكتور؟
احنا بدنا questions in the profile.
الإيج والسكس.
Age. What else? طب who inquired about the age? Why you are interested in the age?
Why you are interested in the age?
يلا يا شباب أنا مش شايف interaction يعني this is not a lecture.
دكتور الريسك فاكتور للكولون كانسر بيكون older age فوق 50.
colon cancer in older age. أول شيء إحنا بنعرفش إن المريض عنده كانسر، إحنا حكينا the patient is not happy about his abdomen and his defecation. So if you are going to think of colorectal cancer, what is the relation between colorectal cancer and the age?
بيزيد الانسيدنس.
بيزيد الريسك أكتر من 60، يعني أكتر من 60 سنة بيصير عندهم ريسك أكتر للكولوريكتال كانسر.
أكثر من 60 سنة they have more risk، يعني بصير في اليونجر. Does it occur in the young age group?
دكتور ممكن، بس الريسك بيزيد أكتر بعد 60.
طيب غير الكولوريكتال كانسر يعني الايج بس له علاقة بالكولوريكتال كانسر؟
دكتور عشان نعرف نحط الديفرنشلز المناسبين للإيجز.
ما فهمت مرة ثانية؟
عشان الإيج بيهمنا مشان نعرف نحط الديفرنشلز، يعني في ديفرنشلز معينين بيجوا
ما هو يعني وضحوا لي حتى نشوف شو الأهمية. يعني أنتوا فكرتوا بكانسر وحكيتوا الكانسر increases with age.
مثلا لو فكرنا بأشياء diverticulosis أو هاي الأشياء، إذا مثلا congenital للchildren أكثر أو زي هيك، بيهمنا العمر بهاي الحالة.
طب الدايفرتيكولوسيس إيش علاقته بالإيج؟
عشان الأنواع تاعونه إذا كان congenital أو لا، يعني true أو false.
بس احنا بيزيكلي لما بنحكي على diverticular disease it's the acquired يعني the congenital is rare. شو العلاقة بين الايج والdiverticular disease؟
اللي عمرهم 50% وعمرهم 80%.
So again the incidence of diverticular disease increases as we get older. So colorectal cancer occurs at any age, but as we get older, the incidence increases exponentially. Diverticular disease also increases, especially after the age of 40, again exponentially. What about inflammatory bowel diseases? احنا بنحكي the patient is not happy about his abdomen and defecation. شو الايج تبع الدايفرتيكولار ديسيز؟
دكتور الدايفرتيكولر ولا الانفلاماتوري باول؟
الا inflammatory bowel disease sorry.
بين 30 لل50.
Is it؟
يعني بالميدل ايج بتيجي تقريبا.
حد عنده جواب ثاني على الانفلاماتوري بول ديسيز؟
وممكن في بعض الأحيان يكون باي موديل.
اوكي شو هم التو مودز؟
بالعشرينات وبعدين بتيجي فوق 60 إشي زي هيك بتذكر يعني.
So usually it's a disease of the young in their 20s وفي another peak in the 50s. فإذا الage distribution بيختلف عن الكانسر والكولوريكتال disease. Anyhow, these are examples just to show the importance of the age in the profile. What else other than the age in the profile? أنا عم بركز كثير على البروفايل لأنه it is ignored by most of physicians. نحكي the patient is not happy about his abdomen and his defecation.
الرئيس.
يا ريت نرفع الصوت لأن أنا في عندي ضوضاء في الباك جراوند بس مش بإيدي.
الرئيس.
Again.
الرئيس.
الريس. شو له علاقة بالكومبلينت؟
البلاك ريس بيكون أكتر ماشي مع الكولوريكتال كانسر.
Not really. وحتى لما بكون في differences من ناحية الريس في الكولوريكتال كانسر ال differences are minimal. طيب يعني حتى ما ضيعش وقتكم كثير. الage. طب الجوب is it important؟ في علاقة بين الجوب و abdominal discomfort and defecation problems؟ Anybody can think of anything؟
ممكن ما بعرف يعني إذا إلها دخل هون، بس إذا في بيكون الجوب فيها heavy lifting وأشياء بتأثر على الأبدومين ممكن تعمل hernias obstruction strangulation.
على abdominal discomfort و defecation symptoms.
maybe بحالة الكولوريكتال كانسر إذا في radiation بالoccupation.
It's not that relevant في الكولوريكتال كانسر، يعني بجوز مثلا بالثايرويد كانسر.
دكتور الموفمنت والفود انتيك، يعني مثلا ممكن حدا بيضل قاعد طول اليوم ممكن تأثر على البول هابت تاعته، والفلويد انتيك يعني مثلا ما في مجال بيكون ياكل أو يشرب أو هيك. يعني حسب إنه الهابتس تاعونه.
يعني احنا بنعرف انه sedentary life is more associated with cancer. But this is not a striking thing. طب where the patient is living, is it related to the defecation symptoms and abdominal discomfort?
أكيد في مرات infections بيكونوا endemic to certain areas.
زي ايش؟ اعطونا امثله.
زي مثلا schistosomiasis بالقاهرة.
Schistosomiasis is endemic in certain areas.
أول مكان خطر على بالي هو صراحة القاهرة، لأنه بعرف إنه كثير فيه بالنيل.
في يعني في دول النيل، يعني ايجيبت ان جنرال، مش شرط القاهرة. بس
دكتور
يعني انتوا، يعني انا توقعت والله انه يعني الصورتين ينبهوكم. هلا احنا لما بنحكي abdominal the patient is not happy about his abdomen and he's having a defecation problem. طب ما حدا فكر بالinfectious causes؟
دكتور الجاستروانترايتس مع
لا مش gastroenteritis.
يعني البولوشن بالووتر هيك.
Colitis. The infectious causes of the colon and to a lesser extent the intestine. شو في famous infectious causes بالcolon؟ سمعتوا بالاميبايسز؟ وين موجود الاميبايسز؟ وين بنشوفها؟ And shigellosis, the dysentery, amoebic dysentery, in areas where there is poor sanitation, open sewage system, contamination of the water with the sewage. هلا انتوا لانه your thinking is concentrated to a tertiary hospital where we see the complicated cases like cancer, but you forget that there are infectious diseases that simulates the diseases like cancer and diverticular disease, etc. Actually, if you work in a primary care center and you want to deal with patients who are having defecation problems, راح نحكي هلا من خلال السياق what are the defecation symptoms and abdominal discomfort. You will find more infectious causes than tumors or inflammatory bowel disease. And you should ask about smoking as well, in addition to other things. But when it comes to the abdomen and defecation, the profile should include these things. So the age, the job, place of living, and smoking. So our patient is a 65-year-old male patient. He's a manual worker working in the sewage system. He lives in a refugee camp and he's a smoker. So these factors are quite relevant to somebody who's having abdominal discomfort and defecation symptoms. We have spent some time on this, but please always remember the profile, and always in the profile there are relevant things, whatever the complaint is. Even the patient, if the patient is presenting with cough or jaundice or headache, you will find relevant things in the profile. طيب, having a positive history of abdominal pain, what are the most relevant questions in this regard? What do you want to ask about his pain?
Site
Site.
والonset إذا sudden ولا gradual والprogression تبع البين.
Of course, yes.
وإذا البين فيه radiation لأي مكان تاني.
يعني احنا بدناش نعيدهم كلهم، بس خلينا نركز على most relevant things. So the site of the pain and the relation of the pain to defecation. احنا بنحكي the patient is having abdominal pain and defecation symptoms. So what's the relation between these? The character of the pain. and the relation to defecation. So our patient is having his pain in the lower abdomen. It's a vague type of pain. It increases during defecation and relieved after defecation. And we like to use the 4-quadrant or the 9 regions in describing the site of the pain. Type. What's the importance of this, the site of the pain and the character? How does it make a difference when we say it's a lower abdominal pain and it's a vague type of pain?
اللور abdominal pain بيعطيك فكرة عن السايد اوف ذا باثولوجي أكثر من
كيف يعني تقدركوش تحكوا عموميات يعني قربوها بأمثلة يعني.
يعني يا دكتور إذا اللور abdominal pain أكيد مش هنفكر بupper intestinal obstruction مثلا أو ببيبتيك ulcer gastric or duodenal.
ليش مش حتفكر بأوبستراكشن؟
لا مش هفكر بupper obstruction.
Where do we feel the pain? What will decide the site of the pain and the character of the pain?
كيف يعني يا دكتور مش فاهم السؤال.
لا السؤال واضح. What will decide where do we feel the pain and the character of the pain?
We feel the pain in the lower abdomen.
There are 2 types of abdominal pain, and you should be aware of that. The somatic type of pain and the visceral type of pain. The visceral is caused by the distension of the viscus or ischemia of the viscus, or when there is contraction against obstruction, which is included with the distension as well. And the site of this will depend on the embryological origin of the organ. So organs coming from the foregut, like the lower esophagus, stomach, duodenum, will be felt in the epigastric region. The viscera coming from the midgut, from the lower part of the duodenum or the ligament of Treitz to the transverse colon, to the distal transverse colon, will be felt in the umbilical region. And the hindgut will be felt in the hypogastric region. And this pain is vague and poorly localized. So the patient will use the hand like this, will move the hand vaguely. The patient is unable to pinpoint the pain. That's why we feel the peptic ulcer pain in the epigastric region. And even the visceral part of the gallbladder pain is felt here. That's why in the early appendicitis we feel the pain in the umbilical region. And that's why in the distal colon and rectum we feel it in the hypogastric region in a vague manner. Contrary to that, the somatic type of pain is well localized and it is felt where the peritoneum is irritated by the causative agent. That's why when there is acute cholecystitis, you feel it in the right upper quadrant localized. When there is appendicitis, you feel it in the right lower quadrant or right iliac fossa. In diverticulitis, you feel it in the left lower quadrant. And it is well pinpointed by the patient, sharp pain. That's why in appendicitis, the pain starts by vague paraumbilical abdominal pain and then shift and localize in the right iliac fossa. Gallbladder pain starts vaguely in the upper abdomen and then localizes in the right upper quadrant. The Diverticular pain starts vaguely in the hypogastric region and then localizes in the left lower quadrant. So it's very important to know the character of the pain and the site of the pain, because it gives you an idea about the causative agent. When the peritoneum is irritated diffusely, the pain will be generalized type of pain, whether the causative agent is pus or intestinal contents or feces or blood or urine or chyle. And this irritation is what gives us the physical findings of tenderness, guarding, and rigidity, localized or generalized according to the irritation. So when we say our patient is having his pain vaguely in the lower abdomen, it indicates that we are talking about a visceral pain from the hindgut region. But you have to remember here, if there is an obstructing lesion in the distal colon, you will have the pain also in the paraumbilical region, because when there is dilatation and distension, this will include the transverse colon and the ascending colon. So you are having the midgut and the hindgut involved. بعرفش واضحة الأمور هاي؟ Hello?
واضحة دكتور.
What are the relevant bowel symptoms? What do you want to ask this patient about his bowel?
إذا صار أي change بالبول habit.
Any change in the bowel habit, like what?
يعني إذا قل الفريكونسي أو زاد والكونسستنسي تاعت الديفيكيشن نفسه.
قصدك الستول نفسه.
sorry.
So you want to ask about the bowel habit, frequency, and about the stool characteristics, the shape, the consistency of the stool. And what matters here more as an indication of a recent problem is the change. Again, the blood in the stool, ما ذكرته. Mucus in the stool, ما ذكرتوها. So you ask about a change in the number of bowel motions. دائما ركزوا على كلمة change. Patients may have chronic problems. They may have a chronic diarrhea or chronic constipation. It indicates a chronic long-lasting problem, but the change indicates a recent problem. Change in the caliber of the stool and the characteristics of the stool, the consistency. So the change in the shape may be decrease in the caliber or fragmentation, and the consistency from hard, stony hard to firm, to loose, to fluidy, to watery. And there are special charts. The most famous is the Bristol stool chart that deals with the characteristics of the stool. So our patient is having an irregular bowel habit. There is alternation of diarrhea and constipation. The patient noticed that the stool is becoming fragmented. The consistency of it varies between hard and loose, and there is no blood and no mucus. So these questions should be asked about the bowel in a patient who is having an abdominal complaint and defecation complaint. What are the relevant defecation symptoms? Symptoms related to defecation.
Straining,
Straining,
tenesmus,
tenesmus,
ممكن feeling of incomplete
Feeling of incomplete evacuation, yes.
urgency and incontinence.
Urgency. يعني الانكونتيننس احنا بجوز ما بنعتبرها defecation symptoms، بنعتبرها symptom more related to the anal canal، لكن في تداخل بينها وبين الارجنسي، تداخل مش انه نفس المعنى. So you ask about straining, urgency, tenesmus, which means there is a desire but nothing is coming out, and feeling of incomplete evacuation. So straining, feeling of incomplete evacuation, tenesmus, urgency, and there is a symptom which is feeling of an obstructed outlet. Some clever patients can describe that. The patient will tell you that I feel the bolus of stool, I strain, but I feel that the outlet is obstructed. This is different from tenesmus. So our patient is having all these positive. He started to strain. He's having feeling of incomplete evacuation. Sometimes he's having the desire but nothing comes out. There is urgency, and he feels an obstructed outlet. What does this indicate when they are present? Hello?
Either obstruction or irritation.
Sorry?
Obstruction or irritation.
Where is the problem when there is problem with defecation?
بالsigmoid and rectum. Mostly يعني. Usually بالcolon.
It is basically a rectal problem, but of course it may involve the sigmoid and the rectosigmoid. So the more the problem is in the rectum or near the rectum, the more you will have defecation symptoms. Because the rectum is the site where we start having the desire. When the pressure in the rectum increases to a level, there will be an afferent impulse to the spinal cord, and then an efferent impulse for the bowel to contract and for the sphincter to relax. That's how defecation occurs, provided that the circumstances are suitable. If not, then consciously the brain will interfere to block that reflex. So the more you have of these symptoms, the more you are in or near the rectum. Of course, you have to be sure that the straining, the feeling of incomplete evacuation, the tenesmus are coming after the desire to defecate. Because some patients, they may have some sort of discomfort or distension, and they go to the toilet in an attempt to relieve that. بمعنى, they did not go because they have a desire. They went in an attempt to relieve these symptoms, and nothing will come out, but this is not tenesmus. So these symptoms should be in response to a desire to defecate. And regardless of the pathology, if the rectum or the distal sigmoid is involved by the pathology, then the patient normally will have the desire to defecate, or abnormally when there is a disease. What are the relevant anal symptoms? You want to be sure that this patient's problems or defecation symptoms are not coming from the anal canal. So what can you ask about the anal canal in order to evaluate it. What are the symptoms related to the anal canal?
Anal pain,
Anal pain,
إذا في mass or a lump,
mass or lump,
anal fissures.
إذا في discharge,
sorry, again,
Fissures.
the fissure is a sign, it's a disease. أنا بحكي symptom.
Bleeding.
Bleeding, discharge, حكيته discharge. So anal pain, lump, blood, discharge, incontinence. It's the function of the anal canal and the sphincter, of course. So anal pain, bleeding, discharge, lump, incontinence, and itching. So the more you have of these symptoms, the more you will think of the anal canal as the cause. Our patient is having all these negative except he's having a small lump. So when you asked him about a lump, he said, yes, there is a small lump. So what do you need to ask about the anal lump?
إذا في pain أو لا باللمب هاي.
احنا حكينا عن البين كسيمتوم لحاله، احنا هلا بدنا على اللمب نفسه.
لا قصدي إنه tenderness لما يعملوا لها touching أو إشي.
Tenderness is a sign.
إذا بتروح
إلا إذا هو بيحكي إنه أنا لما بحسها بتألم بتصير سيمتوم. بنسميها pain on touching.
إذا بتروح spontaneously أو لما يعني هو manually، يعني مرات بتروح اللمب لحالها.
Is it reducible or not? If it is reducible, does it reduce spontaneously or manually? أول شيء, is this lump coming from inside or it is outside the verge? لأنه في مريض ممكن يقول لا يحكي إنه there is a lump or mass outside، ومريض آخر يقول it's coming from inside. هلا if it is coming from inside, does it stay or reduce? And if it reduces, does it reduce spontaneously or digitally? And of course, the associated symptoms. So our patient told us that the lump is coming from inside. It occurs only on defecation, and it reduces spontaneously and not associated with other symptoms.
دكتور سؤال.
What sort of lumps can come from inside to the outside and then reduce? أعطوني أمثلة that fits this.
دكتور ممكن الريكتال prolapse.
Prolapse.
دكتور ممكن أسأل سؤال بس؟
Again.
ممكن أسأل سؤال؟
تفضل.
اللمب on defecation يعني اللمب ما بتطلع غير لما the patient defecates?
Yes, when on defecation and then reduces.
Okay.
يا spontaneously يا manually. شو في lesions أخرى ممكن تعمل هيك؟ Hemorrhoids can do that. Rectal polyps and to a lesser extent tumors can do that. What are the other relevant abdominal symptoms? احنا سألنا على البول symptoms. أول شيء we describe the pain، بعدين البول symptoms، بعدين defecation symptoms، بعدين anal symptoms. هلا بدنا abdominal symptoms relevant.
Distension.
vomiting,
Distension, vomiting.
Pain.
So distension and vomiting. Why we are interested in these two symptoms in addition to the ones that we have mentioned?
obstructions.
يا ريت ترفعوا صوتكم لأنه قلت لكم عندي مشكلة في نويز في الباك جراوند.
الobstruction ممكن يبين
Yes.
and vomiting.
Because the pain, the constipation, distension and vomiting are the cardinal symptoms of obstruction. And another symptom, which is feeling of a mass, because some patients may tell you that I started to feel a mass in the abdomen. So these are the relevant abdominal symptoms. Our patient described distension, but there is no vomiting and no abdominal mass. If a patient tells you that I am having distension, سواء in English distension أو انفاخ بالعربي, what could the patient mean by that? بحكيش pathology, what he means by distension. ما معنى كلمة distension عند الناس؟
إنه يكون في انتفاخ يا هواء يا فلويد.
لا أنا ما بحكي لكش السبب، بقول لك المريض شو بعني. أنت جالس جاء مريض قال لك والله أنا عندي انفاخ، شو بقصد هو يعني أنا عندي انفاخ؟ Well, you have to be sure what does the patient mean, because this word means different things to different people. هلا المريض اللي بصير عنده increase بالsize of the abdomen regardless of the cause بقول لك أنا بطني انتفخ، سواء كان فلويد ولا غاز ولا ماس ولا فات. The patient who is passing a lot of gas بقول لك عندي انفاخ. ما سمعتوا مرضى حكوا لكم عندي انفاخ وطلعوا بعنوا إنه they pass a lot of gas. Some people they mean tight abdomen and tense abdomen causing discomfort. بقول لك بطني منفوخ، يعني قصده إنه he's having a tense abdomen. So the word distension means different things to different people. And when the patient says, yes, there is distension, you should know what does the patient mean by that. Because there is a difference in your evaluation and interpretation between somebody who is having an enlarged abdominal girth or size and somebody who is passing a lot of gases or somebody who is not passing gases. What are the relevant general symptoms?
weight loss,
Weight loss,
anorexia or loss of appetite,
loss of appetite, anorexia,
fever,
fever,
Tiredness.
What's that?
Tiredness.
Tiredness.
Pallor.
Pallor. So pallor. Loss of weight. Jaundice. Fever. So you ask about pallor, weight loss, loss of appetite, fever, and jaundice. Our patient gave a positive history of pallor, loss of weight and loss of appetite, but no fever and no jaundice. Having a positive history of pallor, what are the relevant questions in this regard? What do you want to ask this patient who is having pallor?
ممكن أسأل عن الدايت تبعته لأنه البالر means anemia. ممكن أسأل عن الدايت تبعه إذا بياخد enough greens وميتس وهاي القصص.
Yeah.
bleeding.
يعني انتوا كأنكم عم تسألوا الآن على ال causes of anemia، بس قبل هيك بدنا نتأكد انه he is having anemia from the symptoms.
إذا عنده tachycardia أو palpitation.
Palpitation مش tachycardia. Tachycardia sign. Palpitation.
Postural hypotension.
Again, this is a sign, but a symptom. If the patient lies for a good period of time and then he stands up suddenly, he will feel dizzy, or he will feel like a black curtain in front of his eyes. بنسميها black out. So tiredness, palpitation, dizziness, blurring of vision, headaches, dyspnea on exertion. So tiredness and fatigability, blackouts after long recumbency, headaches, palpitation, dyspnea on exertion, blurring of vision. Our patient is having all these positive. So what does this mean?
إنه البيشنت is losing blood.
Why losing? ليش تفترضي losing?
إنه عنده أنيميا.
It means that there is anemia. It's not enough to be pale, to be anemic. But the presence of these symptoms, in addition to pallor, indicates that there is anemia. What are the relevant points in the past history?
إذا البيشنت كان عنده past surgery.
Previous surgery.
Previous bleeding incident.
Similar attack in the past. You need to know, is this a recurrent disease or this is the first attack of a recurrent disease or a new disease? History of tumors, history of surgery. Of course, you need to take a full past history, but I'm talking about the quite relevant things in a patient who is having abdominal pain and defecation symptoms. شو في diseases مشهورة إنه it comes in attacks تعطي abdominal pain and defecation symptoms.
inflammatory bowel disease.
Inflammatory bowel disease. Diverticular disease comes in attacks. Why the history of tumors important in this patient?
ممكن يكون metastasis أو إشي ضل من التيومر فرجع كمان مرة.
ممكن يكون this is a metastatic disease or recurrent disease, or the symptoms are related to the treatment that the patient had received. Our new tumors in people who are having the inherited cancer syndromes. Why surgery is important?
لأنه بعد السيرجري ممكن يصير في adhesions فبتعمل obstruction.
يعني نتوقعش الادهيجنز تعطينا defecation symptoms. The cause of the surgery, the indication of the surgery may be related to the presentation. بلكي عامل surgery لinflammatory bowel disease, diverticular disease, tumors. So it was negative in our patient. What are the relevant points in the family history?
إذا في أي family member عنده نفس السيمتومز أو صار معاه نفس السيمتومز.
similar complaints. شو أهميتها؟
ممكن يدل إنه هذا الإشي hereditary يعني لأكتر من حدا يعني.
اوكي. لاحظين إنه برضه نسيتوا الانفكشس كوزز. مش فاهم many
ما هو لسه
members
بدنا
share the same environmental conditions and housing. So it may indicate sharing the environment or sharing the genetic background. غير similar condition, family history of what? Tumors. Family history of tumors. We may be dealing with the same tumor or a tumor that is shared in the inherited tumor or cancer diseases. And bowel infections should be broad-minded. إذا العنوان تاعنا كانسر لا يعني إنه we deal with this as a cancer. لكن ليش إحنا عم ناخذ history بتفاصيله examination بتفاصيله. So our patient, when you asked about a family history, he said yes, there is a family history. So what do you need to ask in this regard?
دكتور ممكن أسأل مين الممبر بالفاميلي اللي صار فيه
Who
يعني father.
is having that? And
when they had the attack.
sorry?
When?
The age, yes. كمان
إذا أي حدا مات إذا صار في أي death نتيجة
يعني
هذا.
هذا تصفي details. What is the tumor? The type of tumor. the persons involved and degree of relativity, and the age at the diagnosis. طبعا كل ما كان number of persons and the degree of relativity أكثر كل ما زادت importance. Our patient told us that his mother had uterine cancer at the age of 50. So remember this. What are the most relevant signs on general examination?
Distension.
Sorry?
Distension.
General. ما بنعرف الجنرال اكزام parameters. What's that?
Vital signs.
Vital signs.
The vital signs. How does the patient lie in bed? Is he in pain? Is he comfortable? Is he rolling in bed? Is he unable to make any movement because that creates pain? Eye examination for pallor. احنا بنحكي على signs الآن. Jaundice. So the status in the bed, the vital signs, pallor and jaundice. طبعا ما بقلل من أهمية الفايندينجز الأخرى، بس أنا بدور على إشي quite relevant to what we are talking about. So our patient is lying comfortably in bed. His pulse is 110 per minute. He is pale and he is not jaundiced. What's abnormal in these parameters?
The pulse rate.
The pulse rate and the pallor. What are the most relevant signs on head and neck exam? Of course, you need to do a full examination. بس أنا بحكي most relevant على البرزنتيشن اللي عملناها لمريضنا.
GVP.
JVP.
إذا في عنا lymphadenopathy.
Lymphadenopathy. JVP and lymph nodes. مش معناته نفحصش الثايرويد والتراكية، بس بنحكي عن most relevant. So what is this sign? Virchow's lymph node, the left supraclavicular lymph node. What does it indicate when it is enlarged?
أتوقع metastasis للlymph nodes.
From?
Gastric cancer.
Any abdominal malignancy, not only gastric cancer, but it was famous with gastric cancer. So any abdominal malignancy can do that, including pancreatic and colon. Of course, it is not the only lymph node in the neck. We have different lymph nodes in the neck. The cervical lymph nodes, the submandibular lymph nodes, the submental, occipital. All these are important and may be related to the abdomen because they may indicate tuberculosis. They may indicate lymphoma, and these affect the abdomen. So the JVP and lymph nodes and our patient was having a normal JVP and no enlarged lymph nodes. What are the most relevant signs on chest exam?
effusion.
Fusion. طب شو الساينز يعني؟ Effusion is a diagnosis. Pleural effusion, yes. What are the signs?
Delta percussion.
Dullness, decreased air in,
Decreased breath sounds.
decreased breath sounds, and our patient was not having signs of pleural effusion. What are the
دكتور
most
ممكن أسألك
relevant
سؤال؟
signs on abdominal exam?
دكتور ممكن أسأل سؤال؟
طبعا.
What is the relevance of pleural effusion بالcase تبعتنا؟
Metastasis to the lung. Because that is what you can pick on exam. If the patient is having a nodule, you will not find it on exam. Small metastatic nodules. You only pick metastasis if it has caused pleural effusion. And
تمام
there
شكرا
are inflammatory problems in the abdomen associated with effusion as well, like pancreatitis, liver disease, liver infections, abscesses. What are the most relevant signs on exam, abdominal exam?
Organomegaly.
Organomegaly,
tenderness.
decreased or
Tenderness.
increased bowel sounds.
increase or increased bowel sounds,
Shifting dullness.
shifting dullness,
Masses.
masses. انتوا تعلمتوا انه احنا في عنا inspection و palpation و percussion و auscultation. These are tools, the tools of examination. Out of the tools we pick signs. فبنقول بالinspection decrease movement with respiration, pain on coughing, distension, dilated veins, scars. These are signs. بالpalpation في signs of peritonitis, tenderness, guarding, rigidity. في بالpalpation organomegaly. في بالاuscultation increased bowel sounds or decreased bowel sounds. في percussion you can pick tenderness and you use it for ascites. Out of these signs we come up with conclusions. فأهم conclusions إحنا بنطلع فيها is there obstruction or not. يعني لما بنحكي إنه في distension وفي increased bowel sounds بدنا نستنتج إيش؟ إنه في obstruction ولا لا. لما بنقول في the abdomen is not moving with respiration, the pain is having pain on coughing, there is tenderness, guarding, rigidity. شو بيعنين هدول الساينز؟ بيعنين peritonitis. إذا localized معناته localized peritonitis، إذا generalized peritonitis. Masses, ascites, and organomegaly. إذا إحنا في عنا tools، في عنا signs، في عنا conclusions. هاي أهم الconclusions اللي إحنا بدنا نطلع فيها من الabdominal examination. Is the patient obstructed? Is there any form of peritonitis, masses, ascites, and organomegaly? Our patient was not having any of these. And if there is distension, you should describe that distension. لأنه distension can be generalized like this, and this can be gas or fluid. This is pus in the peritoneal cavity. So this patient will be having tenderness, guarding, rigidity, and being generalized. معناته these findings are generalized. This is the peritonitis signs. And this is the septic look of the patient. Masses. And if there is any mass, you should describe the site of it, the size. Is it intra-abdominal or in the abdominal wall? Is it tender or not? So there is a difference between this mass and this mass, for example. لما حكينا على distension, this is distension, but it is not generalized زي المرضى هدول. لاحظوا إنه distension mainly in the upper abdomen and the right side. شوفوا lower abdomen كيف collapsed and the left side is collapsed. Look at this patient. هذا اللي هون بالمناسبة fat. Look at this distension. And look at this depression here. So in this patient, this is a stomach distension. And of course, the findings of obstruction. هذا أشعة بس يعني مشان أذكركم إنه we look for the findings of obstruction. These are the plain X-rays of air fluid levels. And these are the lying or supine films showing dilated loops. And these are CT scans of obstruction. You see how there is termination of the colonic shadow. Again here, see the colon and it ends here. These are dilated small bowel loops. And this is the air fluid level. This is the gas, this is the fluid. What you see here is the explanation of what you see here in plain X-rays. Masses, enlarged organs. This is an enlarged liver, smooth enlargement. This is a nodular enlarged liver. So you have to remember that there are tools, there are signs, and there are conclusions. And whenever you examine an abdomen, you should come up with the conclusions of obstruction, peritonitis, masses, organomegaly, and ascites. How you are going to complete your exam?
Digital rectal examination.
By the digital rectal examination. Or the per-rectal exam. What you will be looking for in the rectal exam?
Blood.
Blood.
Bulge.
Bulge.
Fecal impaction.
What's that?
Fecal impaction.
Fecal impaction.
Prolapse.
Prolapse. So the first thing you look, because you may see lesions outside, can see hemorrhoids, fissures, opening of fistulas, tumors, pruritus site, scratching. Then you ask the patient to strain. You may see something coming out. And then you put your finger. You examine the sphincter. You examine the stool. You examine for masses. And you examine the prostate as well. So you look for external lesions. Ask the patient to push for prolapsing lesions. Examine the sphincter, masses, blood and mucus, and the stool characteristics. So nothing on inspection, but when we ask the patient to push, we saw circumferential piles in this patient. The sphincter was normal, no masses, and on the finger we found dark blood and mucus. And the stool was loose. So remember that we found dark blood and mucus, but in the patient's history there was no blood. What's your differential diagnosis at this stage؟ هلا احنا بدنا نجمع كل شيء من البروفايل. 65, smoker, lives in a camp, working in the sewage system. He's having abdominal pain, vague in the lower abdomen. ذكروا معي شو حكينا كمان. He's having the defecation symptoms, straining, urgency, feeling of incomplete evacuation, tenesmus, feeling of obstructed defecation. He described a lump in the anal region on defecation and reduces spontaneously. There is a family history of uterine cancer. On examination, he was pale and tachycardic, and on examination of the anal region on straining, we found prolapsing hemorrhoids and dark blood on the finger. So what is your differential diagnosis at this stage?
inflammatory bowel disease.
شو في إشي ماشي مع inflammatory bowel diseases؟
البيشنت عنده blood بالريكتم لما عملنا digital rectal examination، والتشينج بالباول هابتس كانت ماشية معاه، الويت لوس، السموكينج، يعني هالأشياء ماشية مع الانفلاماتوري
طيب بس لو احنا حكينا بدنا نلخص الانفلاماتوري باول ديسيزز بكلمتين ثلاث، شو بنقول؟
It's a relapsing remitting chronic infection.
اوكي symptoms، ومش infection inflammation بالمناسبة. symptoms
إنه بيكون pain و change بالباول habits.
No, this is not enough. This is very broad. Bloody diarrhea and mucus. Is this patient presenting with blood as a symptom? Is this patient presenting with diarrhea as a symptom? كان عنده alternation. الهيستوري ما في blood، احنا لقينا dark blood بالاكزام. لكن عنده defecation symptoms. مرضى البروكتايتس yes they have all these symptoms. طب ليش بصير عندهم مرضى البروكتايتس urgency و feeling of incomplete evacuation و tenesmus و straining؟
لأنه بالريكتم.
طب هو ما في increase بالبريشر اللي يعطي stimulus. The stimulus here is the inflammation.
irritation.
Yes, the inflammation. That is the stimulus. بالنسبة للريفلكس ميكانيزم ما بيميزش. What else can this patient be having?
rectal polyp.
شو في عنده إشي يعني بيمشي مع بوليب؟
اللump that is reducible
ما
after
احنا بالاكزامينيشن شفناها prolapsing hemorrhoids. It's a second degree hemorrhoid لأنه it appeared and disappeared spontaneously. يعني ما بدكم تقولوا كانسر يعني؟ شو ماشي مع كانسر in this patient؟
the alternation of defecation of constipation and diarrhea,
The
positive family,
alternation of constipation, the alternation of bowel habit.
positive family history, smoking,
لا قبل البوزيتيف
age.
خلينا في المريض نفسه. The change in the stool characteristics. The defecation symptoms. So colorectal cancer piles بتفسر بس الاشي اللي بتعلق بالبايلز. Infectious proctitis, inflammatory bowel disease. كلهم بعطونا the defecation symptoms والأنيميا، لكن بعطوا ديارية بس بنتوقع يكون في بلد وميوكس، مش alternation ونو بلد بالهيستوري. لكن ممكن يكون alternation انه attacks of diarrhea during the active phase وبعدين change. So that's the range that we are dealing with. طب إذا colorectal cancer, where do you expect the lesion to be?
Rectal.
Rectal or near the rectum, because that will explain the defecation symptoms this patient is having. طيب, what is your list of the simple most relevant diagnostic investigations? Simple.
CBC.
CBC.
stool by culture testing.
Stool culture and analysis for infection and for blood. Our patient showed a hemoglobin of 8.5 and a positive stool for blood and mucus. What is your most relevant diagnostic investigation?
Colonoscopy.
Colonoscopy. And on colonoscopy, we saw this lesion in the upper rectum. So what it is suggestive of and what is the next step?
Suggests tumor.
Suggestive of tumor. What sort of tumor لما ناخذ الجروس pathology?
Polypoid or fungating.
No.
في ulcer بالنص.
This is an ulcerating lesion. You see the tumor and you see the ulcer in the middle. So what do you do?
Biopsy.
Take a biopsy. So this is another colonoscopic view of a tumor. This tumor is causing narrowing of the lumen. And the result proved adenocarcinoma. What is the next step?
CT.
So what you are up to?
بدي أعمل
Right.
staging عشان أشوف إذا في
The
lymph
clinical
nodes.
type of staging. Because the staging is pathological. This is the clinical part of the staging. And this includes a CT scan of chest, abdomen, and pelvis. In rectal tumors, we like to do a pelvis and pelvic floor MRI. It is much more relevant to the rectal tumors because it gives us more details about the local extension of the tumor in the pelvis. We may do a PET scan if we have unclear suspicious lesions on CT or MRI. And general evaluation of the different systems of the body. Because this patient is going to embark on an aggressive treatment journey. So you need to be sure of the fitness of his systems. Most of the patients that we lose in the post-operative period, we lose them because of failure of their systems. Renal failure, respiratory failure, MI, or stroke. 4 weeks ago, we lost a patient because of stroke. But nothing could be done before the surgery because the patient was obstructed and we need to do it urgently. So this is the MRI. انسوا الإشارة الحمراء هاي مكانها غلط. This is the rectum. هاي هون الساكرم، شايفين كيف الساكرم هون. This is the rectum and look at this tumor, how it is involving the rectum, and this is the remaining lumen in the rectum. طبعا في details يعني كثيرة بتهمنا بالMRI ما بدي أغلبكم فيها. And this is an example of the PET scan. This is an isolated lesion, abnormal lesion in the liver. And here we have multiple liver lesions indicating metastasis. And these are CT scans showing multiple lesions here, single lesion here. This is an ultrasound of the liver showing a mass. This is a brain showing metastasis. This is CT of the lung showing metastasis. So that's how we evaluate the patient regarding the extent of the tumor locally and systemically. طيب, how can you explain the absence of blood in the history? The patient is anemic. His hemoglobin is 8.5. We found the blood on digital examination, and the stool is positive for occult blood. How can you explain the absence of blood in the history?
دكتور ممكن البيشنت ما شافه يعني ما تطلع على الستول.
The patient does not look, and a lot of people, they do not look, by the way. So many people do not look. Or the blood is dark, and the patient doesn't know that this is blood because to him blood is red. So many people know that the blood is only bright red. So don't expect a patient with melena, for example, if you ask him about bleeding, to tell you, yes, I have bleeding. So many physicians doesn't know that we have a spectrum of colors for the blood between bright red and black. The patient does not look at the stool, as so many people does. The patient is having poor vision. Remember that you are not looking on a big thing on the wall or the ground. You are looking about a little bit of blood with the stool in the toilet. So you have to remember that the blood can be anything between red and black. Having a mother with uterine cancer, do you think this is an inherited cancer that is this patient is having? Do you think that the colorectal cancer, the rectal cancer in this patient is part of hereditary non-polyposis colorectal cancer؟ كون الأم عندها uterine cancer؟
يعني ممكن بس مو شرط.
It is possible, but we don't have enough criteria. So what are the enough criteria to say that this is an inherited cancer? احنا بنحكي clinically، بنحكي genetically، يعني انت ممكن تفحص هذا المريض وتتأكد genetically انه this is inherited. But in the absence of the genetic testing, what are the enough criteria? The Lynch syndrome or hereditary non-polyposis colorectal cancer بالنسبة لكم اعتبروه نفسه، يعني لأنه البعض بيعمل بعض الفروقات، أو الكانسر فاميلي syndrome. The criteria are 3, 2, 1. 3 members, 2 generations. طبعا 3 members يعني at least one of them should be the first degree relative of the other، يعني مش الله أي واحد من الحمولة. إذن 3 members, 2 generations and 1 young below 40. And the tumors involved are not only the colon and the other tumors considered part of the Lynch syndrome. And these are the uterine, ovarian, gastric, small bowel, urothelial, and skin appendages tumor, like tumors of the sweaty glands or hair follicles, in addition to the colon. So as you see, the breast cancer is not part of them. Pancreatic cancer, prostate cancer are not part of them. So you need 3 members, 2 generations, and 1 young, considering all these tumors. In Lynch syndrome, the colon cancer risk is 50 to 80. The endometrium cancer, around 50% of them will have endometrial cancer. So as you see, colon, endometrial, stomach, ovary, the hepatobiliary not included, urinary tract, small bowel, and the sebaceous glands. طب if genetic testing proves that this is inherited، احنا عملنا له genetic testing طلع this is inherited colorectal cancer. How can you explain the absence of enough family history؟ ليش ما طلع عنا إلا بس أمه عندها uterine cancer؟ ليش ما اكتمل نصاب الانهerited colorectal cancer، علما انه it is inherited by genetic testing؟ يلا استخدموا ذكائكم وفهلوتكم.
دكتور ممكن يكون في ناس ماتت قبل ما يبين عليها الكانسر؟
يعني
هم ما تسجلوا كحالات انه عندهم كانسر لانه ماتوا قبل ما يكتشفوا.
اوكي. أول شيء the patient doesn't know all the details of the family history. مش في كثير منا لهم يعني أقارب عايشين برا ومش الكل بتكون العلاقات مفتوحة بخبروا بعض شو طلع عندهم يعني. The patient is hiding. في ناس بخبوا المعلومات لأنه بدهم مش يصير في ستيغما إنه هذه الفاميلي فيها كانسر كثير. Some relatives have died from other causes before they had the chance to develop cancer. يعني عنده الجينيتيك predisposition بس مات مثلا بكار accident، لو ظل عايش كان صار عنده. Some relatives are having the genetic defect and they will develop the tumor in the future. يعني ممكن هلا حد من اخوانه عندهم الجينيتيك ديفكت ولو نيجي بعد 10 سنين راح نلاقي انه في عنده. ونتذكر انه البنترانس for inherited colorectal cancer is 80%، يعني لسه في عندنا 20% they will have the genetic defect but it will not show phenotypically. شايفين قديش في pitfalls للنيجاتيف family history؟ طيب what's the plan of management هلا؟ Come on. Number one, counseling. You need to sit with the patient and talk to him. You have to confirm from the CT scan that there is no metastasis. You have to ensure the fitness of the other systems. And in rectal cancer, usually we start by neoadjuvant radiochemotherapy. Followed by surgery. What are possible local symptoms that may occur in this patient? لنفترض إنه التيومر was left for some time and it extended locally. What it can produce? نرجعكم على السي تي سكان نورجيكم بلكي تتذكروا.
دكتور ممكن يعمل
أي التيومر.
دكتور ممكن يعمل فيستولا مع اليورينري بلادر.
Exactly. Bladder invasion. And what will be the symptoms in the presence of bladder invasion?
UTI من colon normal flora.
UTI is right, but this is not enough, an enough description.
Persistent.
Recurrent resistant urinary tract infection. Fecaluria. Nematuria. This is one of our patients. This is the sigmoid, this is the rectum, and this part is the urinary bladder, and the yellow thing is the tumor. Vaginal invasion. And the patient will start passing feces and gas through the vagina. And resistant vaginitis. This is a rectal tumor, and this is the urinary bladder, and the tumor is invading the urinary bladder, and this is gas in the urinary bladder. Is it possible that this patient may come to the emergency room, not to the outpatient department? Can colorectal cancer present to the emergency room?
Yes, في 20% to 25% بيجوا ب
Why?
acute symptom. يكون في عندهم bleeding و obstruction.
مو كلهم بصير عندهم bleeding، معظمهم عندهم bleeding.
يعني massive bleeding.
Massive bleeding, obstruction and perforation. So massive bleeding, perforation and obstruction. What are the main concerns in surgery for rectal cancer? شو peculiar thing في rectal cancer surgery؟ كيف بتختلف عن surgeries for other colon cancer, let's say, and other cancers? The continence. Can we keep the continence? Can we avoid stoma? So the issue of continence is peculiar to the rectal cancer because we are near the sphincter. The recurrence of the tumor is higher than colon cancer locally بحكي لأنه في limits للسيرجري تبعتنا because we are bounded by the pelvis. The urinary and sexual complications are high because the nerves related to these are there in the pelvis, in the field. So when we say counseling, these are the issues that need to be discussed in addition to the general issues of major surgery, mortality, morbidity. These things should be discussed specifically. And in addition to the neoadjuvant issue, so the patient will know that there is chemotherapy and radiotherapy. What are the types of surgery related to rectal cancer? What can we do for rectal cancer surgery? Either we resect the sigmoid and the rectum, leaving the anal canal, doing an anastomosis, we call it anterior resection, or you remove the sigmoid, the rectum, and the anal canal, leaving the patient with a permanent colostomy, we call it abdominoperineal resection. So if that is the tumor, if you resect it leaving the anal canal, you do your anastomosis بين الدescending والanal canal. We call it anterior resection. This operation is done through the abdomen, anterior. If the tumor is lower than that and you need to remove the rectum with the anal canal, the patient will have a permanent colostomy. We call it abdominoperineal, AP. AP مش anterior posterior, abdominoperineal لأنه بنشتغل في الأبدومين وبنشتغل في البيرينيوم. And it can be done laparoscopic or open. This is the end colostomy, permanent colostomy. This is an ileostomy. If we do this operation, if we do the anastomosis, we may do a temporary ileostomy in order to allow the anastomosis in the pelvis to heal. So this is a permanent colostomy. This is a temporary ileostomy. Again, another permanent colostomy. But this is an open surgery. What is the 5-year survival of such cases? مالكم يعني انتوا تركتوا الجلسة ولا ايش؟ مش سامع اي ريسبونس. لسه الفطور مطول. هلو.
احنا معك دكتور، بس صراحة يعني مو خاطر عبالي انه 5 survival rate.
It depends on the stage among other factors. And these are the figures. Stage 1 around 90%, stage 2 around 70, stage 3 30 to 50, stage 4 less than 10. But the stage is not the only factor. There are other factors, but it is the most important. And how can we achieve some progress in stage 4? Because we started to resect some of the metastases. And in March of every year, we celebrate the National Colorectal Cancer Awareness Month, during which the activities are held regarding colorectal cancer. Any question? I hope that